QT syndrome, short LQTS. So, long QT syndrome is a malignant disorder of cardiac conduction in which cardiac repolarization is prolonged. It's the QTC measurement on the ECG. It is predisposing the patient to sudden episodes of syncope, seizures, or sudden death. The sudden death occurs in 5% if left untreated. LQTS is defined as a QT interval longer than 460 milliseconds. Like you see on the picture, you can see from the start of the Q wave until the end of the T wave. That's the QT interval. Evaluation includes an ECG that shows a long QTC measurement, 24-hour ambulatory ECG, also called Holter ECG, and possibly an exercise test. There is a commercially available genetic test for the primary genes that cause LQTS. This test is the most helpful in determining who in an affected family has LQTS. Unfortunately, this test cannot completely rule out LQTS due to a 25% false negative rate. Although a QTC of greater than 460 milliseconds is a reasonable threshold, the majority of individuals in this range are not affected. A measurement of 440 to 460 milliseconds is so-called borderline. The mechanism is a pause-dependent initiation of torsades de pointes, a multifocal ventricular tachycardia. It can be congenital or acquired. Congenital LQTS is inherited in an autosomal dominant, which is the more common, or recessive pattern, or it may occur spontaneously. However, this is less likely. The recessive inheritance pattern is associated with congenital deafness and the Jervell and Lange-Nielsen syndrome, with bilateral sensorineural hearing loss and long QTC, more than 500 milliseconds, resulting in torsades de pointe. Congenital LQTS is caused by a defect in one of several genes that code for potassium or sodium channels in cardiac myocytes. The gene mutations results in subtypes of LQTS that have differing presentation and associations, overall risk and environmental condition and activities associated with ventricular arrhythmias and sudden cardiac death have been shown to be gene-specific. The risk of sudden cardiac death is greatest in those with LQT3 gene and occurs most commonly during exercise among patients with LQT1 gene. Auditory and emotional stimuli are provocative in LQT2 with a sudden cardiac death occurring during sleep in LQT3. The genetic phenotypic heterogeneity contributes to the difficulty in diagnosing and managing patients with congenital LQTS. The wide range of QTC values in both unaffected and affected individual as well as age-related variations also confounds the diagnosis. LQTS resulting from altered ventricular repolarization can also be acquired secondary to myocardial toxins, ischemia, or inflammation. This condition also predisposes to ventricular arrhythmias. Numerous medications can also cause QT prolongation. The treatment for long QT syndrome has been exercise restriction, treatment with beta blockade, often propranolol, and possibly placement of an internal cardioverter or defibrillator. Within the next several years, more gene-specific therapies are anticipated. These are my sources, and thank you for listening.